Thank you very much. When I talk to people who are not normally involved with liver transplantation, there's this expectation that it's always associated with severe bleeding. But as we know, that's not necessarily the case at all. And I would like to, as part of this talk, dispel the myth that a prolonged INR necessarily means the patient will bleed excessively. This is a historic slide, you can tell because blood's on the floor, and that would now be in a cell saver. And it was given to me by a surgeon who's since retired, and it was taken in the late 1980s. The median transfusion associated with transplantation has steadily dropped over the last 2 or 3 decades. And typically, the median transfusion associated with transplantation is around about 2 to 4 units. And an increasing number of our patients undergo transplant without the need for blood transfusion. I recently audited our last 200 transplants over the period of late 2009 to 2012. And the first thing that you notice is that a significant number of patients, it's just over 30%, had no requirement for blood or blood product transfusion. And then there's this spread over small number of units. And then there is still a small group of patients that require massive transfusion. Our transfusion is also decreasing with the years. The previous audit showed a median of 4 units compared to 2 in the recent one. But you can see that there is still this outlying group where they have massive transfusion. And our most recent one, the maximum red blood cell transfused was 40. And that's a case I was involved with, and I'll be showing you that as an example later on. One of the biggest predictors of whether a patient will require transfusion is their baseline hemoglobin. And patients who are able to avoid transfusion have a hemoglobin usually above 11. What is very noticeable, though, and has been commented on by many authors, is that the baseline coagulation tests do not help predict whether or not the patient is going to bleed. Now, this is a paper from a very particular unit which achieves outstanding transfusion figures. This is from Luke Mascott's group in Canada. And in their most recent paper, 80% of their patients receive no blood products. It's an extraordinary feat that very few other centres can repeat, but a lot of it is down to meticulous attention to detail, to careful management of fluids, and avoiding any unnecessary transfusion. But again, what he points out is the hemoglobin is the most important predictor of the need for red cell transfusion, and INR and platelet count are not adequate to dictate transfusion practice. But the question is, how is it possible that patients with end-stage liver disease, with coagulopathy, are able to undergo a major vascular abdominal procedure without the need for transfusion? In the rest of the hospital, patients with coagulopathy from liver disease frequently receive prophylactic FFP prior to invasive procedures in the belief that they are at increased risk of bleeding. As I've said, coagulation defects do not necessarily predict blood product requirements. And in this series, patients were just as likely to have no transfusion if the INR was above or below 1.5. And it's been known for many years that, in fact, there is little association between bleeding and the PT or INR. And this was a paper that you wrote back in 1981. And this was directly observed bleeding time from liver biopsy through a laparoscope. And he showed there was no correlation between the bleeding time and the PT. Indeed, when people have done meta-analysis of the various studies, there is little data to support that a prolonged INR actually increases the risk of bleeding. And perhaps the first step we had to start explaining this anomaly was this landmark paper by Tripodi in 2005. Now, the INR is very good for monitoring anticoagulant therapy in patients on warfarin because it's looking at the suppression of the procoagulants. But the INR and the PT doesn't measure the anticoagulant side. And when Tripodi did thrombin generation studies and activated the anticoagulants, the endogenous anticoagulants with thrombomodulin, he showed that in stable cirrhotic patients, thrombin generation is the same as in healthy individuals. And there is now a new paradigm that in stable chronic liver disease, there is a rebalancing of hemostasis. And this paper was produced in the New England Journal of Medicine in 2011. And the rebalancing is due to the fact that the anti-hemostatic drivers are balanced by pro-hemostatic drivers. So the thrombocytopenia is rebalanced in effect by the raised von Willebrand factor levels and reduced levels of the cleavage enzyme. The low levels of the procoagulants, thrombin, etc., are balanced by the fact that there are low levels of naturally occurring anticoagulants and also very high levels of factor VIII. And the tendency to fibrinolysis with high levels of TPA is balanced by low levels of the substrate of plasminogen and also in acute liver failure and cholestatic liver disease by the high levels of plasminogen activator inhibitor. But it's important to realize this is balance in a stable patient. And in health also, there's a very large functional reserve which acts as a good buffer. But in liver disease, the hemostatic reserve is very reduced. So although it's balanced, it's very easy to tip the patient either towards a bleeding diathesis, for instance because of infection, or towards a prothrombotic tendency due to endothelial activation or stasis. And Stephen Caldwell, commenting on that paper in the New England Journal, said that it's a whole old dogma that's going to die hard, but this whole new concept that hemostasis is rebalanced means that we need to look at different ways of monitoring coagulation and the hemostatic state in patients with liver disease and during liver transplantation. And the conventional tests just do not give us enough information. And that's why global tests actually offer significant advantages in this situation. From a single blood sample, they will give us information about the speed of clot formation from initial fibrin formation through clot strengthening right through to any fibrinolysis. And importantly, conventional tests give you no information that's useful about fibrinolysis or about hypercoagulability. And you can use either a TEG or a ROTEM. They broadly give very similar information. The R or clotting time is the time to initial fibrin formation. And it's important to appreciate that that represents the point at which less than just 5% of the total thrombin that will be generated has been formed. The speed of clot strengthening gives information about thrombin generation, and the maximum amplitude gives information about platelet and fibrinogen contribution to overall clot strength. So the TEG has two channels. There are various activators that you could use. We at the Royal Free use two channels simultaneously. We run a native TEG and a heparinase TEG. And the reason we use native is because it's very sensitive to subtle changes, for instance, the presence of endogenous heparin, which you almost universally see at the time of reperfusion, which is why we also run a heparinase TEG to reverse that. ROTEM has 4 channels, and you have the possibility of running more tests simultaneously, should you wish. Both machines, though, allow you to measure the fibrinogen level. So in terms of what we need to know and how we manage patients, we need to know is clot forming and how rapidly, which will relate to clotting factor levels and anticoagulants, and also the alpha angle to thrombin generation. We need to know how strong the clot is, the maximum amplitude, and we need to know, is it stable? Is there any fibrinolysis? And to my mind, one of the uses of viscoelastic tests is not just giving you a numerical value, it's the fact that it's a visual representation of the strength of the clot. And specific defects give very characteristic traces. You can see there a normal trace, fibrinolysis, a patient who's hypercoagulable, which could be due to thrombocytopenia or low fibrinogen. And so it's important to measure the functional fibrinogen in the TEG or the ROTEM as well. And the last trace is a heparin-like effect, which is in the black line, straight line, which is reversed in the green trace with heparinase. Functional fibrinogen gives important information. Now these are 2 examples, patients presenting at the start of the liver transplant case. You'll notice that they both have prolonged INRs, relatively low platelet counts, but completely normal traces, which goes in with this concept of the rebalanced hemostasis. But if you look at their functional fibrinogen traces, they're completely different, and the patient in the lower trace with a functional fibrinogen below 2, if we get into trouble with bleeding, clearly they are going to reach critical levels of fibrinogen and get into problems with coagulopathy far earlier than the patient above who has a fibrinogen above 4. And one of the things that's very apparent when you use viscoelastic testing is that actually over half the patients who present for transplantation at the time of transplantation have a normal baseline TEG. And that is why so many, an increasing number of these patients are able to tolerate the procedure without the need for blood transfusion, because effectively their clotting is working adequately. But you see a whole range of traces. Approximately 15% of patients are hypercoagulable, which you can see with the increased maximum amplitude, and sometimes you also see a shortening in the R value. About 25% are hypocoagulable at baseline. Now, hypercoagulability is something that's been ignored to a certain extent in liver transplantation, but we know that some of these patients will develop intraoperatively cardiopulmonary emboli. and it's reported in about 1% of patients. And if you look at the case reports, quite often these patients were hypercoagulable at or about the time they developed this thrombus. So we were interested in just trying to assess the prevalence of hypercoagulability, and we looked at retrospective cohort just over the 120 patients. And we defined hypercoagulability either as a shortened R value or an increased G value. And the G value is basically a mathematical calculation from the maximal amplitude that's logarithmic, and it allows you to compare values much more easily. And surprisingly high prevalence of hypercoagulability. Patients with PSC, over 85% of them were hypercoagulable at baseline. Half of our patients with acute liver failure were hypercoagulable, and a significant number of patients with NASH were also hypercoagulable. Of the 4 patients who went on to develop hepatic artery thrombosis in our series, 2 of them were hypercoagulable. And there seems to be a difference in terms of the etiology of the disease. And patients with HCV and alcoholic liver disease were much more likely to show this shortening of the R time, which may be due to endotoxin stimulation, which classically causes tissue factor expression and reduces the R time. I think the point, though, is that just because there is a high INR, it does not exclude the possibility that that patient has a prothrombotic tendency. And there is a risk if the patient is hypercoagulable and the INR is treated with FFP, it may actually exacerbate the situation. Now, what about massive bleeding, which is one of the things I was asked to talk about? Baseline coagulation tests are not very helpful in predicting it. I mean, in terms of dissection, it's often as a result of a difficult surgical dissection. There's a lot of portal hypertension and collaterals. We've had problems with tips that have migrated into the cava, and obviously previous upper abdominal surgery, and you can get into difficulties with heavy ongoing blood loss and then the dilutional coagulopathy that could follow that. Hyperfibrinolysis is classically described as occurring at reperfusion, but it can occur at any point during the procedure. And then a particular issue for us in Europe is marginal grafts, the extended criteria grafts and DCDs. And they may have delayed graft function with coagulopathy and the need for very aggressive hemostatic support towards the end of the case. Now, this was the case I mentioned earlier that had a 40-unit transfusion. We started off with pretty normal coagulation, quite a slow dissection. Then at 3.5 hours after we'd started, quite severe fibrinolysis developed in early anapatic period, treated with tranexamic acid. And then at reperfusion, even more severe fibrinolysis and a marked heparin-like effect. But this patient had tips that had migrated almost up to the entrance to the atrium, and it had actually sheared the upper cava as it was taken out. And we had massive bleeding, which was very difficult to control for over an hour. And you can see in example 6, we had severe dilutional coagulopathy. And when it's that severe and that rapid, the best way to manage that is to use factor concentrates, and fibrinogen and PCC. And just an hour after that horrendous trace, we ended the case with normal coagulation. And although this patient received all that hemostatic support, there was no further bleeding, and he went back to ITU and required no further transfusion. This is an example of delayed graft function. And what's interesting here is the late development, an hour or so after reperfusion, of fibrinolysis and then deteriorating coagulation. And I think these show how helpful it is to actually monitor these patients serially and see what's going on. So, in conclusion, how do you manage coagulation during liver transplantation? In the stable patient, it's important to remember they have a very fragile hemostatic balance. And there is no need to give prophylactic FFP or platelets if their baseline TAG is normal. It's very important to be cautious with fluid administration because that can actually exacerbate bleeding by increasing the pressure in the splanchnic circulation and portal venous pressures. It can hemodilute patients, and so it's very important not to overload these patients. But once you get bleeding, the key is early targeted goal-directed therapy based on the viscoelastic tests. And we give FFP if the R time is prolonged, treat the MA with fibrinogen or platelets, and it's preferable to always give fibrinogen first because that will often overcome the effects of the thrombocytopenia. Tranexamic acid for fibrinolysis, and where there's really poor thrombin generation, the use of PCCs. Recombinant factor VIII we haven't used at all in the last 10 years, and the recent guidelines from the European Journal of Anesthesiology say it should only ever be used as rescue therapy. And those same guidelines point out that a lot of the differences in transfusion between centres is due to differences in coagulation monitoring. And by using TAG or ROTEM, the evidence is you reduce transfusion by about 30%. And by reducing transfusion, you help improve patient survival. If you look at these outcome curves, there's obvious dose-related effect of red blood cells, and it's even more pronounced with the transfusion of platelets. So if we avoid that, we improve the situation. And just finally, I was interested, I was at Pittsburgh and worked with Thomas Starzl, and when he wrote up the first few cases of liver transplantation, this is a quote from that paper, that the changes that occur in the coagulation mechanisms during liver transplantation constitute a serious deterrent to success. And what he was talking about was not just bleeding, but also thrombosis. One of those patients died from pulmonary embolism. So I think we need to recognize just how delicately and fragile is the balance in these patients, and they can easily be tipped one way or the other. And the best way to manage them is to monitor them routinely and serially. And that's a picture of our laboratory, and through that door is our transplant theatre. Thank you very much for listening.
Thank you very much, Susan. Thanks for the wonderful presentation on coagulation monitoring and managing blood loss within this short period. I would like to ask the floor to ask questions. Susan, please.
It's very enjoyable. Is there a relevance of using heparinase TEG during transplant, intraoperatively? Which one of the two?
I think that there are certain points where it's of value to see if there's a heparin-like effect. As I said, you always see it immediately after reperfusion, and we don't treat that with protamine, because it's not usually associated with bleeding, but it's a very valuable marker if it persists that the graft isn't functioning well. We also see it in patients with acute liver failure.
And can you suspect a intraoperative HAT, using a TEG that this may likely to occur? Is that a possibility?
there seems to be an association. I mean, HAT is related to all sorts of things, mainly the difficulty of the arterial construction. But I suspect that if there's hypercoagulability, the worst thing to do is give other pro-hemostatic products.
So, thank you very much. It's a pediatric question. Do you think we should be checking routinely TEG rather than INR in acute liver failure patients?
Sorry, should we?
Should be checking TEG, doing the TEG in this acute liver failure setting rather than INR, because we currently rely on INR, give them FFP before procedures. Do you think it's an old test and it's a time to get rid of it?
It's very difficult. I mean, you know, people are very loath to change their practice, and everyone feels safer correcting the INR. But there's been work done by our intensivists and also work done by Todd Stravitz and Stephen Caldwell in acute liver failure, where even with INRs of 4 or 5, some of these patients are hypercoagulable. So I think we need a better way of monitoring them. And I think we need to actually have the studies that will give people the confidence to use that rather than an INR.
I think this will be the last question for this session.
So there's usually an inverse relationship between coagulopathy and my temper. So I always find that as a judge of whether the coagulopathy or not is severe. But many of these patients are very procoagulant before you start, and identifying the very procoagulant patients at the end of transplant, as you've sort of suggested, is as great a risk as the uncorrected. At what point do you instigate prophylaxis against thrombosis at the end of the transplant procedure based on the TEG?
If it meets the criteria of being hypercoagulable, so if the MA is outside the normal range at the end of the procedure, which is highly unusual, if it is, then we give very low dose heparin. But it's a tricky thing to manage. But yes, we do.
And the patient who's losing a lot of ascites post-operatively and is again procoagulant, should we be doing the TEG routinely in these patients to monitor post-operatively?
I think we should. I mean, I don't think there's enough information about what happens to these patients post-operatively. Even in our institution, it's mainly intra-op.
Thank you, Dr. Susan.